doesn't really, that's not like the essential thing. It's your tumors are shrinking and you're doing well and you're feeling better. And so this is a drug that has all of the qualities you want to see. It really works on the vast majority of patients and has a high objective response rate looked at by third parties, which is the harshest way to look at it. The FDA loves that. They really, third parties doing all the work, so it's not, and no doctor saying, guiding it and pushing data around. The FDA does want to see the doctor assessment, but they also want to see third-party review. And so that's what we're doing. The data will come out soon. This is a drug that doctors really like. I've talked to many doctors. You probably have too, Jeff. Doctors want to use it everywhere. They think it works great in urothelial cancer. We have a robustly enrolling frontline trial of EV plus Keytruda, which I hope to report data later this year. We did not submit it to ASCO, but there are some other meetings later this year, like an ESMO meeting or something else. We wanted to have a little bit more DOR, duration of response, to have before we put out our first set of data, because that's very, very critical. And if you put out your set of data before you have that, people could say, well, what's your duration of response? And if you didn't know it, it kind of leaves it up in the air. So I think we wanted to wait till the right time, and we had enough not only response data but DOR data to really say, hey, here's what we have. So we're excited for that later this year. But the immediate trial, the EV-201 trial for approval, is something that you're going to see, soon, within the next week or so. We don't have that much more time to put this out, but it'll come out, and we're excited to put out the data, and provided the data is, I can't talk about the data now because it's until it's put out, it's not out, and provided that the data look remotely similar to the phase 1 trial, you bet we will hustle to get this submitted. And we're pretty good at getting things submitted and working with FDA pretty quickly. So we're going to try really hard to get this moving along. And, I think that, to me, we have room to actually go south and have less response rate and still get approved. But that's not really what we want. Seattle Genetics wants the data to repeat. You just want to say, okay, we did a pretty substantive phase 1, and our goal is to say, hey, our data is just like that. It's real data. Here's real stuff, and here it is again, and gee, it looks the same, and that's the hope. That's what we want to see. To me, that would be the home run, is repeating the phase 1 data, because it's so strong. Yeah. That's where we are on EV.
Yeah, from that perspective, Clay, have you already discussed with the agency just about the design of the confirmatory study, maybe the size and scale of that? Do you want to move up, to earlier lines of therapy aggressively, or do you want to just sort of validate what you think you're going to get in the ongoing study?
Right. Well, we already have a confirmatory study up and running. It's an international confirmatory study, and it's that one is up and running, and it's actually being run by our partner on EV, Astellas. We are running the EV-201, the approval trial, and we're running the combination with Keytruda trial, and they're running the trial that is the confirmatory trial, so that's underway. But so I'm pleased with our progress, and to me the most exciting thing the two most exciting things are getting it on the market to help patients, and then to try to move into frontline. Not necessarily being the confirmatory study, but move it to frontline and with the right regimen. And it might be that combining it with checkpoints could be outstanding. And I'm saying that largely based on the Adcetris results, combining a different antibody drug conjugate with checkpoints, the data was tremendous. And I think that when you have, just the mechanism of how antibody drug conjugates work, I think really makes it a very preferred partner for checkpoint. And we're seeing this with Adcetris, with EV, with LV. You just see it over and over again, and I think it's something that you'll be watching in the future.
Okay, makes sense. Well, same question tucatinib. So that it looks very, very good from the earlier stage data, and there obviously is a real opportunity in breast cancer patients with brain mets. So maybe give us kind of the bookend of kind of what would be, best case, and maybe wouldn't say worst case, but like for ongoing development, like what could you file on these data if you get it, and if not, what would be the requirements to do so?
So our trial called HER2CLIMB is a registrational trial, and it is something that if the data are good, we intend to submit based on. So that's for sure. We are excited with that. We've certainly spoken with regulators about it in U.S. and abroad about tucatinib, and explain what we're doing and where we're going. It is a randomized study, and it's got a couple of endpoints. It's a PFS is a primary endpoint, but it also has OS, and it also has PFS on the brain mets, which are half of the patients enrolled have pre-existing brain metastasis that's measurable, and making it a strict trial. So we have so the effect on the brain mets is also a prescribed endpoint. So those are the three main endpoints: PFS on the entire population, OS on the entire population, and PFS on the brain mets. And that's what the regulators want to see, and we're excited with those three endpoints. And when you look at HER2 tyrosine kinase inhibitors, the first one out the gate was lapatinib or Tykerb, and GSK initially thought that this was going to be this really big thing, and it's going to challenge Herceptin for supremacy in treating HER2 patients, and it was a tablet, so it's easier to administer than Herceptin. The problem is that Tykerb had very weak ability to inhibit HER2 tyrosine kinase, so it just is a weak drug, and so it didn't work that well. And the other thing is it also had interaction with EGF receptor, which is also called HER1. And the HER1 interaction gives you a lot of GI toxicity. So it had toxicity and it wasn't very active. It did get approved. It is used globally, but it's not a great drug. And it never will be a big drug because doctors can't depend on it. And then neratinib came out, or Nerlynx as the trade name, and it's much more active, much better inhibition of HER2 tyrosine kinase, and so in that respect, really a positive step forward. But it also interacts with HER1 EGF receptor very strongly, and as a result, even stronger GI toxicity. Now, despite that GI toxicity, and despite that some women can't even stay on the drug very long and have to come off because of the side effects, they do have really nice data and have shown data in multiple different trials to be positive. And I actually think that bodes very well for tucatinib, extremely well. I'm always happy to see neratinib doing well in trials because tucatinib was selected in the chemistry lab, was selected based on the strong ability to inhibit HER2 tyrosine kinase, but it was also selected to not interact with HER1 EGF receptor. And the first two drugs, lapatinib and neratinib, were not selected that way. They were selected on their ability to inhibit HER2 tyrosine kinase, but that's it. So they weren't really screened for these other ones and picked out and said, let's pick one that does this but not that. So tucatinib is a little different, and we think that could differentiate it in a very important way for patients. What we've seen is the tolerability of tucatinib, and we've reported this and lots of times, is extremely good. Patients can get on this tablet and stay on it. And one of the good things with HER2 tyrosine kinase is you want to keep pressure on the tumors. And that seems like a really important aspect of using HER2 tyrosine kinase is to keep that pressure on the tumor. And you can do that with a well-tolerated drug in much better way than you could do it with a drug that is not well-tolerated and you can't stay on it long-term. And yes, it works, but the patients are coming off. So we looked at all the data from the multitude of trials that were done on this drug, and it performed tremendously well everywhere we looked. single agent, combination agent, different regimens. Every regimen we looked at, the data we thought was really strong. So we are in this study called HER2CLIMB, and enrollment is absolutely spectacular. We passed, some time ago, we said we were past the enrollment for the 480 for the primary endpoint, and we're getting really close on the enrollment for the 600 patients for the full. We just decided to continue enrolling, and the regulators were fine with that, and so we're close to finishing that. And I'm really excited to this year come out with the data. Now it's event-driven, and so we just we haven't given any more color other than that the primary endpoint will be hit this year, and that's still where I am on it. I'm not going to say anything yet. We may choose at some time in the future to narrow that, but right now, we want to make sure we get this right, and it's event-driven, and so we track events and we speak to regulators. I can tell you, very briefly, with something that Wall Street almost never asks, but I will give you some guidance on. For both EV and tucatinib, we work extremely hard on the CMC aspects, or what we call